Hello, I'm Jesse McQuarters, editor of Step Brand Studio, and I'm pleased to be joined today by two leaders from ADVI Health. Pete Kardel, Vice President, works with real-time healthcare claims datasets across Medicare and Medicaid to help evaluate how new policies could affect reimbursement. Sheetz, head of SAVES, which stands for Strategic Analytics, Value, and Economics, uses data to build models that help clients understand and prepare for the impact of health policy changes. We'll be discussing the evolving CMS regulatory landscape, the Inflation Reduction Act, and what these changes mean for pharma and biotech companies. Pete, Caitlin, thank you for joining me.
Thanks for having us.
The CMS regulatory landscape is in a constant state of evolution. From the Inflation Reduction Act to changes in how certain services are paid for, it always seems like new policy is always on the horizon. What are some of the most significant CMS changes that you believe will have the greatest impact on pharma and biotech companies over the next 12 to 8 months? And what proactive steps are the most forward-thinking companies taking right now to prepare?
Yeah, so in the next 18 months, we will have the first two rounds of MFPs go into effect for IP26 and IP27, as well as the drugs that are selected for IP28 announced. As more drugs are selected and more indications and patients are being impacted by these new lower drug prices, we're going to start to see stronger signals of the secondary effects of these policies. For example, will we see shifts in market share? How will Part D plans react? And how will this impact changes to formularies? Will pharmacies continue to stock these medications? So companies will want to understand these secondary effects and how they're going to impact their business. Having access to data to help inform forecasting and modeling will be critically important. Also, staying at the forefront of incoming policies and guidance that's released by the administration will help companies to stay prepared.
So let's go one by one and address some of these upcoming regulation changes. Let's start off by talking about the Inflation Reduction Act. Given that real-world evidence is a key component of drug price negotiations, what are the biggest challenges companies face in generating and leveraging this data to inform their strategies?
One of the biggest challenges manufacturers often has is just a very clear understanding of how their drugs are behaving in the real world. The manufacturers are setting up the clinical trials. They are often very robust, very restrictive. The manufacturers are just know all the ins and outs of it. But once their drug is now into the general population, into providers who may not be giving it as it was, maybe originally intended, or to patients who would not have been in the clinical trials. What this means is that the outcomes that they're used to seeing in these clinical trials are not what they are going to be seeing in the real world evidence. So manufacturers need to have a better understanding, really as soon as they can, as their real world evidence is developing and maturing. Some of these effectiveness can be demonstrated by taking into account certain variables, such as certain comorbidities that individuals are having, certain clinical characteristics, patient demographics, provider characteristics, things like that. And once you've examined the data and have a better understanding it and better ways to control for spurious variables, it is then you can sort of find and pull out the where the effectiveness story is. Also, the manufacturers need to have a better eye for understanding the outcomes that CMS cares about the most. Those oftentimes are not the same things that manufacturers are evaluating when they are developing their medications. CMS cares most about things like drivers of cost, as well as quality in Medicare, such as hospitalizations, downstream ER visits, complications, and long-term healthcare resource utilization. So just having a more firmer understanding of all the various complexities that involved with real-world evidence will help manufacturers in their negotiation with the federal government.
And then looking ahead to the 2028 Medicare MFP negotiations, what are some proactive steps that manufacturers could be taking to prepare their evidence packages for that?
Yeah, so I think first manufacturers need to know if one of their drugs is going to be selected. So having an understanding of where their drug sits relative to others is important to planning. But for those that are likely to be selected, it's going through the elements of Section I and the evidence package and determining what evidence they already have and have developed and identifying where the gaps are. So this includes identifying therapeutic alternatives, understanding treatment patterns, comparative effectiveness of their products versus others, and understanding prevalence and cost estimates. Some of the questions are specific to Medicare population, so understanding how these drugs are used in Medicare patients is very important. So manufacturers can design and execute on studies that use recent Medicare data to address the gaps and help differentiate their products, demonstrate value, which will ultimately help in the MFP negotiations.
Looking now, there's the October release of the 2026 Part D formularies. What are you seeing as the most significant changes for manufacturers, and how are they using data analytics to kind of navigate these new designs?
Yeah, so the new Part D benefit design went into effect at the beginning of this year, and this capped patient out of pocket at $2,000 and put manufacturers on the hook for liability in the initial coverage phase and catastrophic. This, combined with 2026 being the first year of the initial 10 MFPs going into effect, I think manufacturers are interested in understanding any formulary changes that plans are making in reaction to the implementation of these policies. We know that in this year, there was decreased coverage and increased utilization management for drugs where the manufacturers were specified or specified small, and plans had increased liability under the new benefit design. So as the benefit design from 25 and the MFPs come into play for 26, we'll be continuing to track formulary changes, and stakeholders can also use historical PDE data to better understand plan and drug level utilization and model out potential impacts to their business.
And then beyond drug price negotiations, how are CMS changes influencing how manufacturers approach market access and reimbursement?
The current administration is, set to, as all the administration before it, set to modify Medicare and help streamline it and to make it a more efficient provider of healthcare services. Beyond the price negotiation, the way that's really been a focus recently has been in the skin substitute, which is a very important part of the Medicare spend each year. It makes up a large number of patients and a significant portion of spending. And CMS is attempting to create a new payment rate calculation for these skin substitute products. And this payment structure is currently undergoing finalization with the OPPS and the physician fee schedule rule. And then once that rule is finalized in this mechanism, or whether CMS delays the implementation of this mechanism, manufacturers are going to need to know in modeling and going through various exercises, what this new payment structure means to them and what it's going to affect them and affect their communication and to the marketplace, to the providers doing it. And it just gives, highlights the emphasis of how the research that we do can help our clients with their market access questions.
All right, so let's talk a little bit specifically about oncology. We live in an era of precision medicine. There's so much changing. With new oncology products coming to market, how are companies using data to identify early adopters and navigate the unique reimbursement challenges in this therapeutic area?
Manufacturers with new products coming to market are, commonly looking for companies like us who can help them by accessing an administrative claims database for Medicare or other different payers. And we can help them understand the market in a couple of ways. First, if the product or therapy that they're providing currently has competitors on the market, what we can do is we can evaluate those providers that are currently giving that product or therapy to patients. And we can identify high volume practices, high volume providers. We can help them identify, just where the market basket is and where it could possibly shift with the introduction of their product. The second thing we are doing to help is just when there is no product in that sort of class of therapy, we are helping to identify those early adopters, seeing those physicians or providers who are, and so we can have an understanding of their charging practices and billing practices, have an understanding of when what they're being paid, and if it's going to be motivating or inhibiting for other providers to come on board. And additionally, we can have a better understanding of the patient's clinical characteristics and demographics, and have an understanding of geography of where they are, and And so this just helps them to identify when there are challenges in the treatment landscape, and then know how much resources they should be pouring into it to make any corrections or put out education materials to providers and physicians.
So let's close and talk about your upcoming presentation at ISPOR EU, which is focused on COVID. Can you tell me a little bit more about that? And are there any lessons that we can glean from that presentation as we look forward to the rapidly changing regulatory landscape?
We've been very interested in COVID-19 research for multiple years now, as we've helped various stakeholders understand effective treatment, vaccines, we've compared practices and their effectiveness, and done other analytics. And it occurred to us that, the COVID research has sort of taken a back burner recently. And we've not seen anything in the published literature discussing, population-based Medicare rate of inpatient utilization and sort of a deeper dive other than what was available on the FDA and other publicly available websites. And so that's recently what we did as a sort of more of a curiosity to see if there's anything going on, any patterns we could find in the data. And we essentially just looked at the inpatient Medicare fee-for-service patients with an admitting diagnosis of COVID-19. And, to put it succinctly, prior to April 2022, we see a lot of volatility. We see volatility in the usage of ICU. We see volatility in the age that individuals are. We see volatility in the proportions of race of the people coming in. And then after basically April 22, we've seen a very sort of surprisingly stable period of time from April 2022 through 2025. There's less peaks and valleys in the rate that people are coming in, the proportions of race and gender, and everything seems to have stabilized. And based on our analysis, we can answer why that is. We can only identify that it is present, and whether that stabilization is due to new therapeutics, clinical experience treating COVID, vaccine uptake, resistance through infection, or any other factors. We don't really know that specifically, and we don't know if this is going to be changing in the future. But this is the first analysis that I've seen examining this concept very, very recently.
All right. Well, Pete Kardel, Caitlin Sheetz, thank you both so much for taking the time to talk in our StepRent Studio Multimedia Lounge, virtual today. And it's been an absolute pleasure, and thanks for sharing your thought leadership.
Thank you.